Welcome to today's virtual education event on EUS-Guided through the needle biopsy forceps, a transformational change in the diagnostic approach to pancreatic cystic lesions, presented by Dr. Christopher J. DiMaio. I'm Studi Kapadia, Product Manager at STERIS Endoscopy, and I will be your moderator for today's event. Dr. DiMaio is the Director of Interventional Endoscopy at Mount Sinai Hospital. He is also the Professor of Medicine at the Henry D. Janowitz Division of Gastroenterology at Icahn School of Medicine at Mount Sinai. Dr. DiMaio is the founding member of the Center of Advanced Colonoscopy and Therapeutic Endoscopy at Mount Sinai Hospital and is the past president of NYSGE. Today, Dr. DiMaio will present information on clinical and endoscopic approaches to the diagnosis and management of pancreatic cystic lesions, including the clinical application of through-the-needle biopsy, outcomes, and case reviews. Dr. DiMaio, welcome. The floor is yours.
Okay, well, thank you very much. I'd like to thank STERIS for organizing this event and for Endoscopy Now for broadcasting it, and certainly to all of our participants who have joined. Hopefully this will be an educational and hopefully interactive event as we move forward. So my topic today is to discuss pancreatic cysts, and we're specifically going to focus on EUS-guided through the needle biopsy forceps, which are really transforming the way in which we diagnose and approach pancreatic cystic lesions. Here are my disclosures. And my agenda, sorry, I'm just gonna hide that there. My agenda, I will start just by reviewing indications for performing EUS and FNA in pancreatic cystic lesions. I will discuss the role and impact of EUS-guided through the needle biopsy forceps in the diagnosis of pancreatic cysts. And then at the end, we'll talk about some technical pointers to improve your safety and success in using this tool. So the question always comes up, why do pancreatic cysts matter? Well, for one, we know they're very common. Autopsy studies have estimated that up to 20% of the population may have a pancreatic cyst of one kind or another. What we do know are that the majority of these lesions are neoplasms, and the majority of those neoplasms have the potential for malignant transformation. So we all know the grim statistics with pancreatic cancer. So when we find a patient or see a patient with a pancreatic cyst, it is an opportunity to potentially prevent pancreatic cancer. And I think this is a common image that is familiar to gastroenterologists and certainly to patients. It's often incidental finding of a cystic lesion, and then we are faced with the task of not only making a diagnosis, but guiding the patient in the management options. So it's important just to quickly review the different pathologic subtypes of pancreatic cysts. There are more than 10 different types of cysts, and I probably have left some off of this list. What's important to recognize is that the 5 listed on the left side of the screen are the most common ones encountered in clinical practice. Pseudocysts and serous cyst adenomas are benign lesions with no malignant potential. IPMN cysts, intraductal papillary mucinous neoplasms, and MCN, or mucinous cystic neoplasms, both fall in the category of mucinous cysts, and both of these do carry the potential for malignant transformation. Another common cyst is the solid pseudopapillary tumor, or solid pseudopapillary neoplasm, sometimes referred to as a spin tumor. These are also neoplastic growths that do have the potential for malignancy. The ones on the right side are less common, but certainly not less important. You'll see that adenocarcinoma, pancreatic adenocarcinoma, can occasionally present as a cystic degeneration of a solid mass. We see that other cancers can present with cystic components. We certainly know that neuroendocrine tumors can be cysts on presentation. There is a subset of these that are cysts. And then some other less common lesions that are countered rarely, if ever, in clinical practice. So again, when we come back to our patient with this cyst, we have some key diagnostic questions to ask. Number 1, is this cyst a neoplasm? Number 2, is it a neoplasm that has malignant potential? And then lastly, Are there, if yes, are there features suggestive of advanced pathology or cancer already present? Fortunately, over the past decade and a half, there has been publication of multiple pancreatic cyst management guidelines. This first started with the Sinai criteria in 2006, which has been revised multiple times, most recently in 2017. There are European versions of this, and then the two major GI societies have published their own guidelines. Now, all of these guidelines are based on pretty much the same published literature and as well as expert opinion. And they all agree on some common facts regarding pancreatic cysts. And that is what constitutes high-risk features and what constitutes worrisome features. So high-risk features in a patient with a pancreatic cyst, the cyst would be considered one with high-risk features, meaning high risk for cancer or advanced pathology, if the patient had jaundice or any other associated symptoms such as pain or pancreatitis, if there was the presence of an intramural nodule or mass, if the presence of main pancreatic duct dilation, or if high-grade dysplasia or cancer was diagnosed on cytology. Worrisome features, or sort of moderate features, medium features, include a cyst size greater than 3 centimeters, a pancreatic cyst with an associated abrupt change in the pancreatic duct diameter, if there is upstream atrophy, upstream of the cyst, if there's atrophy of the gland, if there is suspicious lymphadenopathy. The growth rate is becoming an increasingly recognized feature, risk factor and feature. And depending on which studies you read, it can be anywhere from 2 millimeters a year to more than 5 millimeters over 2 years. And then any associated elevated serum CA19-9. So all of these guidelines basically agree that any cyst that has any of these features warrants further investigation. So that leads to the main question today, which is which patients with a pancreatic cyst should undergo EUS evaluation. So this is more of a common sense approach in the way I approach patients when I see them basically on a daily basis with pancreatic cysts. I have a number of assumptions I can make, and based off of those assumptions, I can have a common sense approach to managing these patients. So the first issue, or the first factor, is that the majority of cysts occur in older patients who are typically greater than 60. The vast majority of these cysts will be branch duct IPMN. And you can basically make that diagnosis given their age, if you can demonstrate that these cysts communicate with the main pancreatic duct, or if there are multifocal cysts, as branch duct IPMN uncommonly can be multifocal. The only other clinical scenario which can mimic this is patients with chronic pancreatitis that have cystic changes throughout the pancreas, cystic dilation of the pancreatic duct and side branches. And really, that's where becoming a good physician and a good pancreatologist comes into play, because I would argue that most patients with the scenario of multiple pancreatic cysts in a 65 or 70-year-old most likely will be branch duct IPMN, as chronic pancreatitis is quite uncommon, relatively speaking. And you also have to ask your patient, do they have any risk factors for chronic pancreatitis? Most of the time, the answer will be no. And here's a typical example. You see on an MRCP, you see this multicystic lesion, which is in close association with the main pancreatic duct. The majority of these cysts will have low-risk features, meaning they will not have any nodules, they will have a normal main pancreatic duct, and they will be small, such as this lesion here. And you can quote the published literature to your patients, and that the lifetime risk of a branch duct IPMN with low-risk features is somewhere in the 1 to 4% range. Cysts that are less than 1 centimeter, it's almost unheard of that they will develop, or I should say branch duct IPMNs, 1 centimeter or less, have an extremely rare risk of malignant transformation. So in a patient like this, I typically do not offer an endoscopic ultrasound. However, any cyst, whether it's a suspected branch duct IPMN or other cyst, which is causing symptoms such as jaundice, abdominal pain, pancreatitis, or significant weight loss, or any cyst, branch duct IPMN or other, that has high risk or worrisome features, and we spoke about these: nodule, main duct dilation, large size, or significant growth, I feel those patients should undergo an endoscopic ultrasound. Why? Well, as we said, a precancerous lesion with any of these above features typically would warrant surgical evaluation. And the EUS would allow you to confirm these features and potentially provide a diagnosis, not only of cyst type, but potentially of whether or not cancer is present. And again, a common scenario is you have and we'll look at some cases from my practice at the end of the talk. You have a large cyst, 4 or 5 centimeters. It's important to know if it's a large branch duct IPMN, or a lot of times this may just be a serous cyst adenoma. And obviously the management of those entities is polar opposite. And here's just some examples, just so you have an idea if you've never seen these before. Again, another MRCP, normal main pancreatic duct. Here you see this C-shaped cyst communicating with the main duct. You learn over time as you look at more and more images that something like this is not a nodule protruding in. It's actually more of a C-shaped lesion. And this is where endoscopic ultrasound can be important if this was a very large lesion, distinguishing a nodule or not. Here is another patient with a branch duct IPMN, a large cystic lesion here, but here you see massive dilation of the main pancreatic duct. So you have a worrisome feature greater than 3 centimeters, and you have main duct dilation, which is a high risk feature. This patient should undergo an EUS for confirmation and will most likely have surgical evaluation provided they're a surgical candidate. The other end of the spectrum in which patients should be considered for an endoscopic ultrasound are young patients, and typically those less than 50 years old. And why is that? Well, a young patient with a pancreatic cyst has a completely different epidemiology of their cyst and a completely different demographic. So in young patients, I worry about precancerous lesions. For example, mucinous cystic neoplasms are traditionally found in women. 95 to 99% of these lesions are found in women, and they're often in the distal body or tail of the pancreas. And we know these have malignant potential, and surgery is usually recommended. So a young patient with a cyst in the tail, especially a woman, should warrant an evaluation. Again, other tumors which can be seen in younger patients: solid pseudopapillary tumors, again, pre-malignant tumor, and neuroendocrine tumors, also pre-malignant, can present in young patients. Lastly, the young patient with a complex or large cyst, we should also entertain the diagnosis of a serous cyst adenoma, because one, this is not a precancerous lesion and does not warrant surveillance. And so it would be very important to rule this out in a 35-year-old patient so that we don't have to subject them to a lifetime of MRCPs, CAT scans, and endoscopic ultrasounds. And here's a typical example of a young patient with a unilocular cyst in the tail of the pancreas. This is a classic mucinous cystic neoplasm. How about FNA? And so I always counsel my patients that just because we're going to do an endoscopic ultrasound doesn't necessarily mean we're going to do an FNA. So when should we consider doing a fine-needle aspiration? Well, certainly I would consider an FNA if I have a patient with a suspected IPMN that has high risk or worrisome features. There was an intramural nodule, for example. Or if I suspected, based on morphology or patient demographic, that it's a serous cyst adenoma, then I would consider an FNA with the hopes of trying to prove it's a serous cyst adenoma so we can stop surveillance imaging. I would also consider an FNA if I suspected a neuroendocrine tumor, a solid pseudopapillary tumor, or any kind of malignant cystic lesion. I typically avoid FNAs in small cystic lesions, less than 1 centimeter. Why? Well, the cytologic yield, as I'll show you, is quite poor in general. So in a cyst less than 1 centimeter, it's it would be extremely rare to make a diagnostic pathologic diagnosis or cytologic diagnosis. And also for cyst fluid analysis, a 1 centimeter cyst is just not going to give you enough fluid. I would also avoid FNAs in patients with a suspected pseudocyst because you may introduce infection into a sterile collection. This is again where patient history plays an important role. I would avoid puncturing a dilated pancreatic duct. These ducts are typically dilated because they're under pressure. Puncturing the duct will often lead to a leak and pancreatitis, and not uncommonly large fluid collections like pseudocysts. And I certainly would avoid doing an FNA if the patient was coagulopathic or on any type of anticoagulant other than aspirin. Baby aspirin and even full aspirin is fine. And then if I do an FNA and I do get fluid, this is typically how I would triage that fluid. If I have any in the syringe, I typically send it for a CEA level, an amylase, and a glucose level. And you may not be familiar with glucose as a common cyst fluid marker, but there is a growing evidence, recently published evidence, that glucose may actually be the most sensitive test to distinguish a mucinous, cyst fluid glucose, that is, to distinguish a mucinous lesion from a non-mucinous lesion. So I usually send any fluid in the syringe off for those tests. If I have any left over, I'll send it for cytology. And then no matter what, whether I have fluid in the syringe or not, I'll always rinse the needle with saline into cytolite and send that for cytologic analysis. Now, again, we're really talking here about the standard approach to diagnostic workup. This involves cross-sectional imaging with contrast-enhanced CAT scans and MRCPs. It involves endoscopic ultrasound and the various types of fluid analysis that we spoke about, chemical analysis, cytology, and even molecular analysis looking for mutations such as KRAS or GNAS. What we know, and I think we've all experienced this, anyone who's ever taken care of these patients, is that this standard approach is really suboptimal in terms of making a true pathologic or histologic diagnosis. If you look at cross-sectional imaging, the ability of either of these types of scans to make an accurate or predict an accurate diagnosis on a patient is quite poor. It's about a coin flip. If you look at endoscopic ultrasound, CEA, which was really the bellwether of cyst fluid markers that I think we all grew up on, the sensitivity for distinguishing mucinous from non-mucinous cysts is only 63%. So there's a lot of false negatives. Glucose, as I mentioned earlier, has very good sensitivity and specificity in distinguishing a mucinous from a non-mucinous cyst. But again, that's not the same as having a pathologic diagnosis. Cytology is notoriously poor, with the most optimistic of reports showing a diagnostic rate of up to 67%. But usually the sensitivity of cytology for either diagnosing a mucinous lesion or making a pathologic or cytologic diagnosis is quite poor. And molecular analysis, KRAS and GNAS, is very good sensitivity and specificity. But again, all this is really, most of the time telling you is whether or not this is a mucinous cyst or a non-mucinous cyst. And it really doesn't have much impact on whether or not there's cancer present. So the majority of the time, the vast majority of these tests that we perform actually fail to confirm an actual diagnosis. And what you're left with is an awkward conversation with the patient where you're telling them what they probably have. And many times this means that they have a mucinous cyst or a non-mucinous cyst, but you may not be able to tell them for sure if it's a serous cystadenoma, if it's an IPMN, if it's a mucinous cystic neoplasm, or something else. And then again, just to hammer home the point, all of these cyst fluid markers that I'm showing you here, they only can distinguish mucinous from non-mucinous. They do not correlate with the risk or presence of malignancy. The only thing that would be cytology, but again, the sensitivity is quite poor and you're gonna have a lot of false negatives. But so really what we use every day is suboptimal. So we need something better. We need a transformational change where we can actually provide useful information to our patients and to our surgical colleagues and to ourselves so that we know how to best manage these patients. So two novel technologies. One is confocal laser endomicroscopy, or needle-based confocal endomicroscopy, nCLE. And without getting into the specifics of the technical aspects of this, this is basically a tool which is what I describe to patients as a laser microscope that can be inserted through the needle and be used to identify epithelial and vascular structures along the cyst wall. So this typically goes through a 19-gauge needle, and you sort of walk it along the wall. Patients are given an IV injection of fluorescein, which is taken up by the cells and helps enhance their ability to be seen by this laser microscope. And it's been nice. Many investigators have very nicely worked out what typical epithelial patterns and vascular patterns will look like, what cancer will look like compared to benign lesions. And here's just some examples. So an IPMN will typically have a papillary frond on pathology, and here under nCLE, you can see that papillary frond. MCNs are characterized by a thickened epithelial border on pathology, and again, that can be demonstrated with nCLE. Serous cystadenoma, very important lesion because this is always a good diagnosis. Flatly, highly vascular lesion, and that is characterized by a superficial vascular network on nCLE. Pseudocysts, they typically do not have any kind of epithelial pattern, right? Because it's a pseudocyst, there's no real epithelial pattern. And you typically just see this dark background with macrophages and inflammatory cells floating in it. And then neuroendocrine tumors have what's described as a trabecular pattern, these white fibrous areas with intervening blood vessels. And if you look at some of the published literature on the ability of nCLE to make a diagnosis compared to standard modalities, if you look down here at the bottom, you see that nCLE far outperforms CEA, cyst fluid cytology, or the combination of the two in making a diagnosis. It really just sort of blows it out of the water. The other new kid on the block in the novel EUS tool that is really making a major impact is the Moray microforceps, or through the needle biopsy forceps. So very easy to understand. It is a miniature biopsy forceps that is designed to fit within a 19-gauge EUS needle, and it simply allows for direct cyst wall biopsy, where we can send it off for pathology and do an actual histologic analysis of the epithelium and the stroma. So the hope is, and we'll obviously talk a little bit more about through the biopsy needle, but the hope is that, and what I hope to show you is that these tools perform better than our standard analysis, be it cyst fluid or otherwise. And I think the most important thing these tools do is that it really removes the doubt about what we're looking at. It eliminates this whole conversation of you likely have a mucinous lesion or it's most likely a precancerous cyst. Rather, you have a real conversation. You say, this is an IPMN. This is a neuroendocrine tumor. And I think we all want to reassure our patients that we know what we're dealing with, especially if surgery is going to be considered. Nobody wants to undergo pancreatic surgery of any kind if it's based on it's most likely or a probably. And similarly, the surgeons feel the same way. I think they feel very confident when we get a pancreatic cyst with a very high CEA, and perhaps it's a 5-centimeter cyst with a very high CEA, and we think, okay, this is a big branch duct IPMN. But there's always that small chance. I know in my practice, I once saw a patient with a serous cystadenoma that had a cyst fluid CEA of 8,000. So if you're going to be basing surgical decisions, especially things like Whipple, off of these inaccurate tests, you're going to get burned every once in a while. So let's look at some of the data behind the outcomes with the microforceps. So this is one of the first studies. This is a prospective study of 114 patients who underwent EUS-FNA and cyst wall biopsy with the microforceps. The mean cyst size was 35 millimeters, and every patient underwent both an FNA and a cyst wall biopsy. And what we found, or what was found, was that a diagnostic tissue for diagnostic purposes was achieved in 83% of the patients with the microforceps versus only 37% of patients who underwent FNA. In patients that had an equivocal diagnosis based on their CEA value, meaning it was neither very low or very high, that the biopsy forceps were able to diagnose these as mucinous cysts 50% of the time versus only 8.5% of the time when using FNA. For those patients that underwent surgical resection, the microforceps had a 100% concordance. So all 14 surgical specimens had the same diagnosis that was made on the biopsy forceps, whereas only 21% concordance in the FNA group. And this is the example I just gave you. And then also, you know, very interesting and very important is the ability to potentially diagnose advanced neoplasia. And in 4 out of 5 cases, 80% advanced neoplasia or advanced pathology was found on microforceps, was not found on FNA. And all of these are statistically significant. Now, there is some downside, and this is early experience with the new tool. And this report showed that there was adverse events of self-limited intracystic bleeding in about 6% of patients and acute pancreatitis in about 5% of patients. So we have to keep that in mind. The risks of these happening with the standard FNA are about 1 to 2%. This was a recently published meta-analysis. There's multiple meta-analyses. This one included the most number of patients and the most studies, including ours, and I'm going to present ours in a minute. But this was a meta-analysis of 11 studies, about almost 500 patients, and they found that the microforceps biopsies had a diagnostic accuracy of about 79%. In the 59 patients who underwent surgical resection, the diagnostic accuracy in that subgroup was 88%, and an overall sensitivity of making a true pathologic diagnosis of 82% sensitivity and 97% specificity. This was done with a mean number of passes of about 3. And again, when you look at the larger experience as opposed to just one study, you see that the bleeding rate and pancreatitis rate is actually much lower and much more acceptable. And the majority of these are mild. And then lastly, if you look at the plot here, when they compare FMB, the microforceps, versus FNA in terms of making a diagnosis, a true pathologic diagnosis, it clearly favored the microforceps biopsy with an odds ratio of 4.8. So those studies show that, or demonstrate that these tools, the microforceps, is really good and highly successful in achieving a pathologic diagnosis. We recently published a study looking at, well, what is the impact of that? What is the impact of performing microforceps biopsy or performing needle-based confocal laser endomicroscopy on the clinical management of these patients? It's great that we get these new diagnoses, but what is the real clinical impact? So this was a single center study from our institution, retrospective, and we looked at all patients who underwent, with a pancreatic cystic lesion, who underwent what we call the quadruple biopsy. So the 19 gauge needle was preloaded with the confocal probe. So they underwent a puncture, they underwent a laser endomicroscopy exam. After that was completed, the needle was left in place, the probe was removed, and then the Moray forceps were inserted. And it was left to the discretion of the endoscopist, but multiple biopsies were obtained and sent for pathology. Again, the needle was left in place and the microforceps biopsy was removed, and then a standard fluid aspiration was performed, and fluid was sent for CEA, amylase, glucose, and cytology. And then regardless of the fluid sample we rinsed the needle into cytolite for cytologic analysis. Our outcomes were to look at the technical success of this, the diagnostic yield of each modality, and most importantly, what was the potential change in clinical management. So we created something called the composite standard. And this is basically what we currently use. It's our best educated guess when we combine the clinical features of the cyst, the demographics of the patient, the morphologic features based on CT, MR, and EUS, the cyst fluid chemical findings, and the cyst fluid cytology. So basically all the things we're already doing, we compiled we created a composite standard, and based on this, we sort of ranked every cyst of what we think it would be based on this. And then we compared that to the diagnostic yield of nCLE and the microforceps, as well as the management decisions we would have made based on these outcomes. So we performed this in 44 cysts in 44 patients. We had a technical success, which was very high, EUS-FNA of 100%, nCLE was able to be performed in 98%, and microforceps tissue acquisition and microforceps was achieved in 89% of our patients. We only had one adverse event, which was an infected pseudocyst, which was managed medically and ultimately required endoscopic drainage, but we had no episodes of pancreatitis or bleeding. And here we look at the diagnostic yield. So diagnostic yield when using cytology was only 16%. When we included that composite standard, so the morphologic features on imaging, EUS, the patient's demographics, our diagnostic yield was about 34%. Microforceps biopsies, however, by themselves had a 75% diagnostic yield, which was statistically significantly higher compared to the composite standard. And nCLE alone had a diagnostic yield of 84%, which was also statistically higher compared to the composite standard. These two were not statistically different, however. If we look at the combinations, if we add the composite standard, the typical clinical morphologic features to the microforceps biopsy, we had an 80% diagnostic yield. If we added the nCLE to the composite standard, we had an 89% diagnostic yield. And if we combined all of them, we had a 93% diagnostic yield. And again, these are all not statistically different amongst each other. And that may just be a consequence of relatively small number of patients in our study. So the real crux of this study was, what is the overall impact on these findings? So when we looked at the outcomes, we saw that nCLE findings would have resulted in change in clinical management 43% of the time, NFB 39% of the time, and the combination 52% of the time. Again, these are all statistically similar, no statistical difference. The main areas where we had a huge impact were that we were able to stop surveillance in a large number of patients. Here, 45% of patients who underwent MFB were able to stop surveillance, primarily because we were able to diagnose either a serous cyst adenoma or a pseudocyst. Similarly, we were able to cut down on the number of follow-up MRCPs and endoscopic ultrasounds. Again, because we were able to either make a diagnosis of a benign lesion, or we were able to prove that a particular lesion was in fact a pre-malignant lesion, such as an IPMN, and no longer required repeat EUS-FNAs to make that diagnosis. So one question that always comes up is, well, how many biopsies do you need? How many bites do you need to make an accurate diagnosis? You know, we're using a 19-gauge needle. We are seeing potentially increased rates of bleeding and pancreatitis. The mantra we have is sort of, let's get in and get out as quickly as possible. You know, it would be very helpful if we knew how many bites we needed. So this was a very nice study, Italian study published in Gastrointestinal Endoscopy, where they retrospectively looked at 61 patients who underwent microforceps biopsy, and they looked at 4 diagnostic categories. They looked at the ability to determine cyst type, meaning mucinous versus non-mucinous, the ability to evaluate the epithelial lining, the ability to grade the level of dysplasia, and then lastly, the ability to make a specific diagnosis off of these biopsy forceps. And what they discovered was that having 2 macroscopically visible specimens resulted in a histologic adequacy of 100% and the ability to make a specific diagnosis in 74% of patients. And this is what they're talking about, a histologically or a macroscopically visible specimen, something visible to the eye. And I think this was a really, really interesting conclusion. They said that the collection of a third specimen did not add any additional information or change these numbers. So their conclusion was that 2 macroscopically visible specimens should be our goal. Now, interestingly and somewhat disturbingly, they did report a very high rate of adverse events, 23%. The majority of these were clinically insignificant cyst bleeds. So when you take that away, it's a little bit more acceptable, but you still see that acute pancreatitis or clinically significant bleeding and in one patient fever is still possible, and we need to remember this. So I'm going to move off of the data and just talk about some technical tips. And these are things that I've learned as I've used this increasingly in my practice. So the first technical tip is the needle puncture. So as I mentioned, this forceps only fits through a 19 gauge FNA needle. And I should stress that you don't want to use this with a core biopsy needle. It's really designed to be used with a standard FNA needle, but it's 19 gauge. And it can be very difficult to puncture with a 19 gauge needle. It can be particularly difficult to puncture through the thick stomach wall. And it can be particularly difficult to puncture through a cyst wall or through the pancreas. And you really don't want to go sort of like slow when you do this. You really want to have a rapid dart-like puncture. So what I typically do is I will tent the mucosa with my needle tip. And from the tip of the needle, I will measure to the center of the pancreatic cyst, that length, and then I will set my needle break up to that length. And then I will literally slam or do a hard push, rapid push of the needle and slam it or knock it against that needle break so that I'm just sort of shearing through all the tissue and getting a very clean puncture. Similar to how an Olympic diver doing a high dive barely makes a splash in the water. That's really the goal. The other important thing about needle puncture is that you kind of want to anticipate your launch angle. And I know it's like the baseball playoffs and they talk about home runs with launch angles, but I think about this in terms of needle puncture. So for example, if this is your cyst and you were to puncture the needle here, you're really not going to afford yourself a good opportunity to sample much of the cyst epithelium. You're really going to get, barely a quarter, less than a quarter, probably an eighth of the circumference. But if you target your puncture to aim towards the 6 to 9 o'clock region, somewhere around here, you can use a typical fanning technique and you can access much more of the cyst wall epithelium. And again, using a combination of fanning, either with the big wheel or the elevator, and you can access more of that tissue. And that's really what you want to do, is get as much of a sample from throughout the cyst as possible. When it comes to tissue acquisition, this isn't a passive closure of the biopsy forceps. You want to apply slight pressure to the forceps shaft so that forceps can grab tissue. And you want to look for what I call the tent sign. And I'll show you some examples of this. So when you grab tissue and pull back that forceps, you're going to see the epithelial lining or the cyst wall tent up. And that's a pretty good sign that you're going to have tissue. I used to when I started doing this, I would typically do 1 bite per pass. But knowing that each piece of tissue is like gold and we really want to get in and get out as quickly as possible, I will tend to do 2 to 3 bites per pass. And as I said, I will typically use that fanning technique to target different areas. And you really want to, if you can, and you don't always have the opportunity to do this, but if you can, you want to aim for things like nodules and masses. You want to aim for thickened wall portions or septations. And in a cyst that's multi-cystic, that contains multiple small cysts and large cysts, I think it's most helpful to go for the macrocystic components. You just have more room to work with. It's technically easier. You can access more of the cyst wall when you're in a bigger space. And then anecdotally, what I found is when doing this in serous cyst adenomas, You know, those honeycombed microcystic components can be very hard to get good tissue. It can be very hard to open the biopsy forceps, and you often just sort of create a very bloody field. And if you can find the larger cystic component, you have, as I said, you have a little bit more room to work with. And I found more success in serous cystadenomas targeting those areas. Once you have your specimen, you have to process it correctly. So these forceps come with a small scraping tool. It's sort of like a little dental pick. And you can train your technicians to use that to extract the tissue. You have to tell them to be gentle. If they just sort of, you know, vigorously rub the dental pick across the forceps, they may damage or disrupt the tissue. They have to be gentle. Again, you always want to have macro observation. You want to be able to see pieces floating. They are small, but you can see them when you do have tissue. And again, this is a pathologic diagnosis. We're not using cytolite, we're using formalin, and we want to send these to our pathologist. And it's important to familiarize your pathologist with what you're doing, because sometimes they may see a scant piece of tissue and just sort of, you know, dismiss it, but you have to explain to them that what we're giving them is truly microscopic, micro pieces, microbiopsies, and they need to really examine the specimen carefully for these pieces. And this is a little bit beyond the scope of what we're going to talk about today, but this was also recently published in Gastrointestinal Endoscopy, a really wonderful paper, which is a guide, for a pathologist guide for the endoscopist. And this, I think, is a great article that is applicable to both us as endosconographers and to pass along to our pathology colleagues. Last few points in terms of safety. I really don't consider doing this in a cyst smaller than 1.5 centimeters. And again, the reason is puncturing, you have to use a 19 gauge needle. You need to make sure you have an adequate runway and launch angle to maneuver the cyst. And really below 1.5 centimeters, it's unlikely, or it's the chances are much lower, I would say, of getting good tissue and perhaps a safety concern as well. The other interesting observation that our group has made is that every time you withdraw that biopsy forceps from the needle, a small amount of fluid is going to be pulled into the needle channel by capillary action. And your cyst is going to eventually just get smaller and smaller the more times you do exchanges. So the point here is that try to take more than one bite when your biopsy forceps is in the cyst. And then don't do your cyst aspiration until the end, because again, you're going to be wasting fluid every time you withdraw the biopsy forceps. The other safety point is when you reinsert the microforceps into the needle, you don't really have, you may need to unlock the brakes on the scope tip, or you may need to straighten the scope tip to advance the forceps out of the needle. This is really most relevant when you're biopsying the head or the uncinate and your scope tip is angulated. You know, it's 19 gauge needles are very rigid. We often have limited mobility, and sometimes it's just the microforceps is just too stiff, or the scope tip is just too angulated, and you may need to straighten things out temporarily. And then the other important point is when you're reinserting the biopsy forceps through the needle, you don't really have a marker of where to stop. So you have to do this very carefully. You'll often, as the needle tip, or as the biopsy forceps tip is approaching the needle tip, you'll often see air or fluid under EUS being pushed through the needle channel into the cyst. So that's sort of a little hint that you're coming to the tip of the biopsy forceps. It's a real tongue twister to say all this. But it's really important, because that will be the marker that the tip of the biopsy forceps is approaching your needle tip. And you really want to go slow, because if you just do this haphazardly and go fast, you'll perforate the cyst and, you know, lead to pancreatitis and other problems. And then our goal is really to try to do all of these maneuvers with one needle puncture. So that's why you set yourself up for success when you plan this out correctly. And it all comes down to, where are you puncturing that cyst? What is that launch angle going to look like? how much are you going to be able to fan, and how much of that cyst epithelium are you going to be able to access? And so you really want to get it right the first time. And you want to puncture once. You can leave your needle in there between the exchanges of the forceps. And if you want to do things like confocal laser endomicroscopy, as we showed in our study, you can do all of these things in one setting off one needle puncture. All right, so let's go through a few cases. So this was a 54-year-old woman with a history of hypertension and diabetes, history of gallstones in the past, had a cholecystectomy, CVD stones, a distant ERCP. This was all in the distant past. She presented to the emergency room with a bout of intermittent abdominal pain, or bouts of intermittent abdominal pain, and this all culminated in an episode of very severe abdominal pain. On imaging, she was found to have a 1.8 by 1.6 centimeter peripherally enhancing cystic lesion in the pancreatic tail. They note a non-enhancing internal septation. And the radiology read is that the upstream pancreatic duct was obstructed and dilated up to 4 millimeters. And also there was associated acute focal pancreatitis in the tail. So a lot of concerning things going on. There were no solid enhancing components, and the rest of the pancreas downstream from this was normal. So it's really unclear what's going on with this patient. Is this a pseudocyst as a consequence of focal pancreatitis? Is this a neoplastic lesion causing a duct obstruction and resultant pancreatitis? You really can't tell these things. It's a little bit of chicken and the egg. You really can't tell these things from either the history or the imaging. So we did an endoscopic ultrasound, and here we see this unilocular lesion with some septations and perhaps a thickened or nodular component. Here we're puncturing with the 19-gauge needle, which is preloaded with a Moray forceps. And now we're accessing the wall. And I do try to get, you'll see in the next segment, I do try to get some of that nodular component. Here you start to see a little bit of that tenting. You'll see it a little bit better here. And what you see is that as you access that nodular component, it all starts to dissipate. And you see that it all dissipates and becomes this hazy collection of debris and mucin, or what we think may be mucin. So the cytology, so we did cyst fluid analysis as well. So the cytology was that this was negative for malignant cells, and the contents were consistent with cyst contents, basically macrophages and debris. And we sent off cyst fluid analysis for CEA, and it was insufficient fluid. So we're sort of right back where we started with the initial presentation. But because we did the microbiopsy forceps, we were able to get actual diagnostic tissue, which was read as cuboidal and low columnar mucosa with foamy cytoplasm and an associated stroma consistent with the mucinous cystic neoplasm. And if you read the details of the path report, it's quite amazing what they're able to do off of these small samples. They did immunohistochemistry, which was the stromal cells were positive for CD10, estrogen, and progesterone. So you have an ovarian-like stroma with columnar mucosa lining it. It's diagnostic of a mucinous cystic neoplasm. So we recommended that this patient undergo a distal pancreatectomy, which she did, and this confirmed it was a mucinous cystic neoplasm, low grade, no high grade dysplasia or cancer. Second case is a 60-year-old male who presents with a recent pneumonia, underwent cross-sectional imaging, CAT scan picked up something in the pancreas, so that was followed up with an MRI, and it was noted that he had a 4.3 centimeter multicystic lesion at the pancreatic body with a dilated main pancreatic duct. You can see he's had no prior history of acute or chronic pancreatitis. He doesn't smoke or drink, no family history of pancreatic cancer. Here's the MRCP. We see this very complex multicystic lesion. We see a dilated main duct, and a few cuts down, you see that this dilated duct is in direct communication with this cystic lesion. So already we're thinking that this is a branch duct IPMN with high-risk features with main duct involvement, so-called mixed type IPMN. And based on the size and based on the presence of the dilated pancreatic duct, this would be considered a high-risk lesion. Based off of these scans, I don't see anything here that would make me say there's an actual cancer there. But compared to a cystic lesion without these features, this would statistically have a much higher chance of developing cancer. So surgery is certainly on the board for this young man. So we did an endoscopic ultrasound. Here's just the still shot of this lesion. So again, we have a 19 gauge needle preloaded with our biopsy forceps. I apologize, it's a little bit blurry. But here you see that we're able to grab the tissue and really tent up that cyst wall. We have to actually pull quite hard. Sometimes you need your assistant to pull that forceps out for you. But it's just an example of how, you know, these forceps are really, really nice at grabbing a good amount of tissue. So again, typical analysis, the cytology, not surprisingly, was inadequate for a cytologic assessment. The cyst fluid analysis, fortunately, was a big cyst. We had a lot of fluid. High amylase, high CEA, and low glucose, all of which are consistent with a mucinous cystic lesion. So if we stopped right here, we would be telling this patient that based on the scan and based on the cyst fluid analysis, he most likely has IPMN with high-risk features, and he needs a distal pancreatectomy, or this actually would have required an extended distal pancreatectomy. So we did the microforceps, and fortunately, this was able to diagnose and confirm our suspicion that this was an IPMN. And he did undergo the distal pancreatectomy, and it was an IPMN involving both the main duct and side branch ducts, low-grade dysplasia, no carcinoma. But this is sort of the ideal situation. He had a high-risk lesion, main duct involvement, but he underwent a surgery that was prophylactic for cancer. The alternative of just monitoring this and waiting for nodules and masses to develop would have not been the ideal approach. So he underwent a preventative and curative resection. And then this is the last case I'll show, and this is one of my favorite cases. This is a 30-year-old woman who presented with left upper quadrant pain, had a large cyst, 3-centimeter cyst in the distal pancreas, no prior history of pancreatitis, but she had an elevated lipase in the outside emergency room, and she was transferred to us for cyst gastrostomy, for what was presumed to be a symptomatic pseudocyst. So here on an endoscopic ultrasound, we already see, and I'll pause it for a second, we see this unilocular cyst, but now we're seeing a nodule. This is a little unusual for a pseudocyst. You typically don't see a nodule. You may see layering debris or necrotic material, but quite honestly, this was a very mild case of pancreatitis. Most patients with pancreatitis never get a pancreatic fluid collection. So why did this woman, that didn't really make sense clinically, that this young woman with no obvious risk factors for pancreatitis would have developed this big pseudocyst. And now we're starting to see a nodule. The story is just not fitting that this is a pseudocyst. So instead of doing a cyst gastrostomy, we did one of our quadruple biopsies. So we started with laser endomicroscopy. And what we see here is we see these thickened epithelial bands or thickened epithelial border right there. So suggesting a MCN or mucinous cystic neoplasm. And then we followed this with microforceps biopsy. And again, you'll see a nice tenting sign here. And I'm getting more than one bite here. And fortunately, this confirmed our suspicion. This was a columnar epithelial line cyst with an ovarian-like stroma, diagnostic of a mucinous cystic neoplasm. This was the cause of her pancreatitis. Similar to the first case I presented, she underwent a distal pancreatectomy. Here you see that nodule. So again, this was a win. And I can only imagine what would have happened if we tried to do a cyst gastrostomy in this patient. So presented a lot here. I can sum it up with a few overriding conclusions. Pancreatic cysts are common, and they are an important entity. And I think I've demonstrated that. The vast majority of these are neoplasms. The vast majority of them do have malignant potential. The challenge we have is trying to sift out which are premalignant, which may be high risk or malignant, and which are benign. and don't have any malignant potential. Unfortunately, the standard diagnostics that we use with imaging and fluid analysis really do fall short in obtaining a true diagnosis. We spent a lot of time talking about novel advanced diagnostic tools. The through-the-needle biopsy forceps or microbiopsy forceps is one of these tools. And I think I've demonstrated, or I hope I've demonstrated, that the use of this significantly improves tissue yield, which ultimately improves our ability to make a true pathologic diagnosis, and most importantly, has a major impact on patient management. And it's my feeling that incorporation of any enhanced diagnostic tool should be considered when performing an EUS-FNA of a pancreatic cyst. I'll end there, and I thank you very much.
Thank you so much, Dr. DiMaio, for this informative session and this presentation. We will now move on to Q&A portion of the broadcast. Attendees, if you haven't done so already, please submit your questions and comments using the chat box at the bottom of your screen. Our first question today is, do you use Cellvizio and microforceps biopsy on all of your uncharacterized cysts over 2 centimeters? What drives your decision to use like a particular modality?
That's a great question. So it goes back to what I was talking about in the beginning, in that if you start with the presumption that one way you can approach pancreatic cysts is to start with the presumption that all cysts are branch duct IPMN and work backwards from there. So if this is an elderly patient with a 2 centimeter cyst and it's a branch duct IPMN, or I presume it to be, I probably would not do an endoscopic ultrasound unless there was some concerning feature on imaging. If I did do the endoscopic ultrasound, I would only do an FNA if I saw a high-risk feature such as a nodule or dilated duct. And at this point in my practice, if I'm going to subject a patient like that to the risk of a needle biopsy, I will most likely incorporate either the forceps, the biopsy forceps, the confocal, or both. Our study showed that the use of both confocal and the microforceps, it doesn't add anything extra. The yield with using them individually or in combination is not statistically different. And then it just becomes what you're most comfortable with, what you have access to, and things like time limits and all that. So currently, because we're involved in a number of studies, I am using both of them in various ways, and occasionally I'm still using them both in the same patient. But ultimately what drives my decision is, okay, I have a 2 centimeter cyst in a 70-year-old patient, no high risk features. What am I, if I'm going to presume this is a branch duct IPMN, I'm going to do anything further. I'm not sending the patient for surgery. I'm just going to monitor it. Yes, this could be a serous cystadenoma. Yes, this, perhaps the likelihood, if it's just a simple cyst that it's something else, is pretty low. And again, I think I base it on demographics and statistics. So I probably wouldn't FNA that patient.
Great. Another question is, have you considered FNB for cyst epithelial evaluation? Dr. Reza has noted increased post-EUS pain with solid lesions undergoing FNB.
So I'm not sure what they're describing, what they mean by FNB. If they're talking about the use of a core biopsy to get a piece of the cyst wall, there are reports of this. There are published literature on this case series. Personally, I'm a little uncomfortable with this because whenever we do a cyst FNA, our goal should be to not puncture the cyst multiple times because there's a risk of leakage of cyst contents, there's risk of bleeding, and notoriously pancreatitis. So it doesn't make inherent sense to me to purposefully drive a fork-tipped or core biopsy needle through the wall to get tissue. Yes, there is success in getting tissue, but I am not a proponent of that technique. If the question is referring to using the microforceps biopsy, again, I feel that with experience, it is very safe and a wonderful adjunctive tool in making a diagnosis.
Another question we have is, comparing your patient treatment plans post EUS-FNA to now using Moray, what's changed? Are you noticing a change in your surveillance rate?
For sure. And I think our study demonstrated some of those findings. My favorite application, or the most satisfying application of the novel tools, is when you have a patient with a large cyst in the 4 or 5 centimeter range, that when you go do endoscopic ultrasound, it has features typical of or suggestive of a serous cyst adenoma. And it is very satisfying to be able, it's one thing to go out there and say, based on what this looks like, I think this is a serous cyst adenoma. And then it becomes, how confident do you really feel that you can just stop imaging that patient? But there's a different level of confidence when you can get a biopsy and go and tell that patient definitively, you have a serous cyst adenoma, and we do not need to survey you anymore. So in my practice, I think that is probably one of the most common applications of this. The other major application of this is, and I showed you a couple examples, is in young patients. Because often in young patients, cysts, the cysts that young patients get typically are simple appearing, but we know that many of them, neuroendocrine tumors or mucinous cystic neoplasms, MCNs, we know those harbor malignant potential. So if you have a 30-year-old, a 35-year-old with one of these cysts, they're most likely gonna head to the OR at some point in life. The alternative is you tell them you're gonna get a scan every year, every 6 to 12 months for the next 40 years. That doesn't sound very enticing. So it's also very satisfying when you can get a confirmed pathologic diagnosis, and again, guide them to surgical resection with no further surveillance, or if it's a serous cyst adenoma or something else, disband their surveillance. I think more and more, again, the majority of cysts we're all seeing are IPMNs, and the vast majority of IPMNs will never need surgery. So it's the rare case where all the pieces line up, where a patient has a large IPMN. Most surgeons at high volume centers are not removing IPMNs based on size alone. They're really doing it based on presence of nodules, pancreatic duct dilation, or symptoms. So, if you have the 70-year-old with a 5 centimeter cyst and you prove that it's an IPMN, it's unlikely going to change their management unless they have those other high-risk features. And then everybody involved can be reassured that, yes, this surgery is the right move here.
Certainly. The next question we have is, have you used paraffin blocks for specimen preservation? In your opinion, is there a role for putting microforceps samples in cytology?
So the goal of the microforceps, is to get a pathologic diagnosis. I think every center and every institution has different strengths, and I know there are some places where the cytologist can really work magic with simple FNA specimens, and putting this in a cytologic, the advantage of putting specimen for cytology is that you will really capture any loose cells that may be present. But the power of the tool is that it's going to give you stroma, it's going to give you architecture, which is really best visualized by pathology. So I'm not a pathologist, I'm not a cytologist, and I'm not going to pretend that I can speak at a high level to the processing techniques, both of those involved. But my approach when I use this tool is that I want to get a pathologic diagnosis. I would equate it like this. If you had a patient with an esophageal mass, you can brush it for cytology or you can biopsy it. My sense would be that a biopsy would give you much more information in terms of, is it well differentiated or poorly differentiated, as opposed to a cytology specimen. And also with a biopsy, you're just going to get a bigger piece of tissue more tissue to work with, higher chance you're going to be able to do immunohistochemistry if need be. So it's the same concept with what to do with the MFB specimen, cytology or pathology. I think if you're going to do this, you do this with the idea that it's going to be sent for pathology. I have an interesting theory that if you do the FMB, you may be shedding cells into that cyst fluid, so that when you take your cyst fluid specimen and send that off for cytology, you may get a bonus extra yield there. But I haven't been able to prove that, or we haven't proven that. It's just a quirky theory I subscribe to.
Thank you, Dr. DiMaio. Another question we have is, we know pancreatitis is the potential complication for any EUS or ERCP procedure. What is your protocol for managing these complications?
So I think, knowing that the majority of pancreatitis is mild and self-limited is encouraging. But I think when it comes to iatrogenic pancreatitis, be it from an ERCP, be it from an FNA, be it from an ampullary biopsy, we know that patients can get severe pancreatitis. And I can't recall which paper it is, but a colleague of mine has pointed out to me that in one of these studies of FMB, somebody died from necrotizing pancreatitis. A patient died from necrotizing pancreatitis. So I do not treat any pancreatitis lightly. We teach our trainees that they should manage this as an emergency, no different than GI bleeding, because early intervention can really prevent the development of severe pancreatitis, organ failure, and necrosis. So if I suspect, if I do a procedure like this and a patient wakes up with severe pain, I'm keeping them in the recovery area for several hours to observe them. And if I have any concern or suspicion, they're most likely going to get admitted for a rule out pancreatitis. We will start high rate IV fluids in the recovery area and pain control, obviously. But really, we take a very low threshold approach to these patients. You really, especially, I work in New York City, so if a patient's going in or out of a suburb, it can be a nightmare to have to fight traffic, 2-hour car ride home, etc. By the time they get home, they're doubled over in pain. So, we've seen this one too many times that we just have a low threshold to admit them and treat them.
Thank you, Dr. DiMaio. Just a couple more questions. What are your techniques when accessing and sampling more challenging parts of the pancreatic anatomy, such as the Untitled process?
That's a great question, and that's a very challenging issue. What I've experienced is that, I think for the majority of lesions in the head, the majority of the time when we do a standard FNA, we can access it from the duodenal bulb. The rigidity of the 19-gauge needle can limit that. And there are a whole new class of needles available on the market that are made of nitinol or that have more flexibility than the first generation FNA needles. So that would be one thing to consider, is if you're not using a nitinol-based 19-gauge needle, I would consider using that, or maybe some of the other newer needles that are just making their way on the market. That's number one. Number two, if you really can't get the angle from the bulb, then you sometimes have to go in what I call an ERCP position, go down to the periampullary area, reduce the scope, and sometimes you'll be able to access the head and the uncinate lesion from that. And the advantage is that your scope is straighter. The disadvantage is that the scope can potentially be much more unstable. And you're sort of withdrawing the scope, pulling it back. And if the patient, depending on the patient's duodenal anatomy, you may just slip right back into the stomach. So yeah, and often you're doing all kinds of weird things with your body, your back maybe to the patient in order to maintain the torque. But that's typically what I would do. Rarely, if it's a very large medial lesion or a very large uncinate lesion in the medial part of the pancreas, rarely you'll be able to visualize it and access it from the stomach. But more often than not, you're sort of forced to go through a lot of normal pancreatic tissue. And that's what I would definitely try to minimize and avoid. I would also minimize and avoid going through the pancreatic duct. Almost a guarantee you'll give that patient pancreatitis.
Great, thank you, Dr. DiMaio. Just one last question for today. What are your thoughts on the current surveillance guidelines for managing pancreatic cysts? Do you think through the needle biopsy should be added to current guidelines for sampling worrisome cysts?
So I think it's a great question. And I think in the next series, one, we need more data. There are, only a handful of studies published on all these novel tools. And I think as a field, we're still trying to sort out where they fit into the management protocol for these patients. I think in the next, I would venture to say, and I have no involvement in their development at this time, but I would venture to say that I would be shocked if they certainly are not at least mentioned in the next round of guidelines. But I think if we can continue to show these really fantastic outcomes in making a diagnosis, I think they should be incorporated, again, not as a mandatory tool, but as something to strongly consider. I'll give you a brief example. In many of the Asian countries, it's sort of taboo to stick a needle in an IPMN because they have a very real concern about seeding. And again, it may just be different biology with that patient population, but so and a lot of times they're not doing FNA on suspected IPMNs. So again, I think there's a room for a lot of nuance with how we manage these patients, but I think the data will speak for itself. And I think the two biggest factors with doing this are safety and cost, because now you're adding another tool to a needle cost. So I think those things need to be worked out, but the next set of studies will probably focus on cost analysis, in that if you spend X amount of extra dollars to do a biopsy forceps, you're saving hundreds of thousands of dollars in MRCP costs and EUS costs down the road. So just a matter of time for those studies are published.
Great. Thank you so much, Dr. DiMaio, once again for your time and such a great presentation. This concludes today's Q&A and the presentation. Thank you for joining us all today, and a replay of this event will be available on the Endoscopy Now app within a few days in case you would like to revisit the information. Have a great evening, everyone.
Thank you very much. Have a great evening.